Hello, everyone. Welcome to today's webinar session. This is the second of two sessions that we had planned to share the key findings and the insights from the British Columbia edition of the Canadian Atlas of Palliative Care. So a very warm welcome to all of you. Next slide, please. So before we get into our presentation, just want to take a moment to acknowledge the land in which I'm presenting from, which happens to be the city of Ottawa, which is the traditional unceded and unsurrendered territory of the Algonquin Anishinaabe people. And we know that the Algonquin peoples have lived on this land since time immemorial. And I would like to take a moment to acknowledge the historical oppression of lands, of cultures, and the original people in what we now know as Canada, and believe wholeheartedly that the work that we all do in palliative care can contribute to the healing and decolonizing journey we all share together. So very grateful to have the opportunity to be present in this territory. Next slide, please. Okay, so today's presentation is part of the Palliative Care Echo project, which, as I think many of you know, a national multi-year initiative that's really focused on cultivating communities of practice, supporting continuing professional development among healthcare providers right across this country who care for patients with life-limiting conditions. The Palliative Care Echo project is led by Pallium Canada and its hub partners. Again, right across this country, the project delivers a continuous learning journey for healthcare providers to build local capacity to provide a palliative care approach to patients and their families. It's really designed to create what we call these virtual communities of learners in palliative care. We bring together local healthcare providers and community leaders with regional, provincial, or territorial and national subject matter experts, again, to support that continuous learning, to engage in deep dive discussions, national presentations, and interactive case-based discussions. And big thanks to Health Canada, who has financially contributed to the Palliative Care Echo project. But the content and views expressed throughout today's presentation do not necessarily represent the views of Health Canada. Next slide, please. And of course, it's important to understand that the Palliative Care Echo project is not a replacement for foundational training on the palliative care approach through programs like Pallium's LEAP courses. And if you haven't taken a LEAP course, I would encourage you to do so, to acquire the knowledge and the skills and the confidence to provide earlier, more effective, more compassionate palliative care to patients and families, such as the one that you see here on your screen, which happens to be our LEAP Core course. So I encourage you to visit pallium.ca to get more information. This particular course, by the way, is accredited by the College of Family Physicians of Canada for 24 main pro credits for the online and hybrid versions and 28 credits for the in-class version. Next slide, please. Okay, so joining me in today's discussion is Dr. Leonie Herx, who is a palliative medicine specialist practicing in Alberta. She's also a clinical professor in the Cummings School of Medicine at the University of Calgary. She's a research associate with us here at Pallium for the Canadian Atlas of Palliative Care and is a senior scientific director at the Palliative Institute, Covenant Health. So good to see you again, Leonie. Thanks for joining us today. Next slide, please. Again, very warm welcome to all of you. Thank you for joining us. A couple of reminders, your microphones have been muted. It doesn't mean that we don't want to hear from you though. So we would love to get your thoughts, your questions throughout the webinar, and you can express yourself using the Q&A function at the bottom of your screen. And when you do that, you do help contribute to the overall knowledge that's collected over the next 60 minutes. So thank you in advance for engaging. And please remember not to disclose any personal health information during the session. Next slide, please. Okay, in terms of conflict of interest, as I mentioned, the Palliative Care Echo project is funded through a contribution agreement from Health Canada, which of course includes sessions such as these. Pallium also derives funding from the sale of its LEAP courseware and the Pallium Palliative Care Pocketbook. In terms of conflict, I am an employee of Pallium Canada. Leonie is compensated for her role as a research associate with the Canadian Atlas of Palliative Care. Other than that, there's no other conflicts to declare. Okay, so let's get moving. Let's go on to the next slide, please. So, very pleased to welcome you to the second session of our British Columbia edition of the Canadian Atlas of Palliative Care. Real privilege to be with all of you here today. We have a number of colleagues and partners and stakeholders. All of you I know are committed to strengthening palliative care across not just BC, but across Canada. And the Atlas is really part of a larger national initiative to help better understand and visualize palliative care, the landscape of palliative care, if you will, in every single province and territory. And our goal really is to support planning, policy, education, and ultimately system improvements, all grounded in evidence and informed by the voices of those who are delivering and coordinating the care on the ground. So our session today will walk you through the key findings from the BC Atlas and offer some insights into the process behind it and share how this information can be used to inform future work. Next slide, please. So the overall aims of the Canadian Atlas of Palliative Care are to raise awareness of the current status of palliative care in the province. It also serves to improve equitable and timely access to palliative care, identify and spread excellence, guide and inform policymaking and planning and capacity building in the provision of palliative care, and ultimately to enhance the quality of palliative care in jurisdictions across the province. So these atlases have been set up to, as I said, describe the current state of palliative care across a number of different domains and indicators, which I'll talk about in just a moment. We also want to identify and highlight areas of strength. So where are we really strong in palliative care service delivery, and highlight some of the successes. And by doing so, we hope to spread and scale these successes. The Atlas also identifies opportunities for improvement, and it does raise awareness of the status of palliative care for populations who do require special attention. So we're talking about children, 2S LGBTQ2I plus populations, incarcerated persons, recent immigrants, refugees, homeless, marginally housed. And lastly, the Atlas will inform ongoing health system changes and improvements to palliative care to ensure equitable and timely access for all who need it. Okay, so let's get on to the next slide and talk a little bit about the core research team and the authors. Really want to take a moment to extend my heartfelt thanks and gratitude to this team and the authors behind the edition of this atlas. This was a pretty big project, as you will begin to appreciate, and this couldn't have been done without their dedication and their commitment to advancing palliative care in Canada. And they really did, everyone brought together their experience, their clinical practice expertise, their expertise in research, education, system leadership. And I think it really shows in terms of the quality and the thoughtfulness of the work that you'll soon see. And right from the very beginning, the early stages of design methodology, right through to the interviews that we conducted, the analysis of the data, the writing of the report, well, the validation of the data too, of course, the writing of the report. Really, this whole team poured their energy and care into every single step. So on behalf of Pallium Canada and everyone who will benefit from this resource, thank you to these individuals you see on the screen here for their insight and their tireless work in bringing the Atlas to life. Also, on the next slide, want to express our sincere gratitude to the funders who made the BC edition of the Palliative Care Atlas possible. Their support really not only enabled the development of the Atlas itself, but also reinforced the importance of investing in data and evidence to strengthen palliative care across the province. So thanks to their contributions and their patience, this took a little bit longer than planned. We now have a detailed and accessible snapshot of palliative care capacity, gaps in palliative care, opportunities that are unique to the province of British Columbia, and insights that we hope will really serve to guide decision-making, planning, and future investments. So it's a really great example of what we can achieve when funders, health system leaders, community stakeholders all come together with a shared vision for compassionate, high-quality palliative care. So on behalf, again, of the entire team at Pallium and our partners across the palliative care community, thank you to these funders for their commitment to ensuring that people in this province receive the care that they need when and where they need it. Next slide, please. And similarly, we're deeply grateful to the many provincial and regional stakeholders across the province that you see here on the screen who contributed their leadership and time and insights to the project. A big shout out to the BC Centre of Palliative Care, who was our lead provincial partner for this atlas. the firsthand knowledge of the challenges and innovations in delivering palliative care that was provided by all of these organizations really was key in grounding the atlas in the realities of patients, families, and the care teams across the province. Again, there would be no atlas without the collaboration of all these different organizations, whether it was through the interviews they participated in, the data that they shared, or even their guidance. Their input helped ensure that this BC Atlas is both accurate and, most importantly, I would say, action-oriented. Their commitment to improving palliative care access and the quality in the different regions in the province really is evident, and their leadership really continues to set an example for others across the country. So big thank you to them. Okay, so before we get into the data itself, the precursor of the work that led to the BC Atlas actually began back in 2019 in response to the federal government's framework on palliative care in Canada, which did call or has called for better ways to assess and monitor palliative care across the country. And that was the impetus for Pallium to launch the development of the Canadian Atlas of Palliative Care. So we drew inspiration and guidance from the international atlases that have already been developed, thanks to the leadership of the team at the University of Navarra in Spain. And to get started, what we did was we brought together a research team made up of leaders in palliative care and primary care. So we're talking researchers, clinicians, educators from across multiple provinces and organizations, including representation from the University of Navarra itself. And our work began with 2 pilot regions in Ontario, and then it grew to include the development of 3 provincial atlases, one for BC, which we're here to talk about today, one for Alberta, and one for Ontario. Just go back a slide, please. Thank you. Our goal is to ultimately have 13 provincial and territorial editions, each with regional subsections and a federal level atlas that summarizes the status of palliative care at a countrywide level. And that'll, of course, allow for comparisons with other countries. It's worth noting that this edition of the Canadian Atlas of Palliative Care does not reflect palliative care services and programs of First Nations, Inuit, or Métis people. Instead, and we say this with humility and the spirit of reconciliation, of course, Pallium is dedicated to collaborating in a distinct process led and developed by Indigenous peoples to describe palliative care across Turtle Island, provided by and with and for Indigenous peoples. Next slide, please. Okay, so we'll start with domains and elements. So as you can see on this slide, the information that's presented in the atlas is done so across 9 different domains. And within each of the domains are a number of elements. These domains and elements are based on those used internationally, but have been adapted for the Canadian context. They were tested through a pilot study involving, as I mentioned before, 2 Ontario regions. These regions included urban and rural geographies and demographics, and the experiences and the learnings from the 2 pilots informed additional modifications to the process and the domains and indicators and the protocols that were used in this particular provincial atlas. And the different domains and indicators really do allow for comparison across the regions and to provide more detail given the large and varied geographies and demographics that make up British Columbia. Overall, the reporting of results of indicators presented in this atlas that falls into 2 categories. Some indicators are relatively straightforward to identify and measure, such as the presence or the absence of a policy or a law, or the presence of a palliative care unit or a hospice residence, and those are reported as either existing or not existing. In some cases, they exist, but they exist partially. So, for example, the coverage of palliative care medications or supplies in a home setting. And in these cases, we have reported them as partial. But there are some indicators that are quite challenging to measure accurately and across a whole province. So the level of integration of palliative care across all hospital services and across all communities, frankly, wasn't feasible given the resources that we had and the availability of the data and the significant variability that often exists across communities and regions. So for these and in these circumstances, a global judgment was exercised based on multiple input that was received from the different informants. Next slide, please. So to obtain the best possible results and representation of the status across the different domains and indicators that we just looked at, and to reduce the risk of potential biases or inaccurate impressions of both the informants and the researchers, the study used a mixed methods, multi-source and multi-informant approach. So we developed consensus through multiple stakeholder iterative reviews and ensured input from different perspectives and multiple information sources, including health system leaders and frontline clinicians. And once the identification of the domains and the indicators was finalized, we did obtain Research Ethics Board approval and established a collaborative partnership with our key partner, the BC Centre for Palliative Care. And then data collection began with search for publicly available data. And this is searches that were online through various websites and reports. And at the same time, we began to recruit participants in collaboration with the BC Centre for Palliative Care and the regional health authorities. So standardized online surveys were completed by the key informants from the province. And from within the regions and from within the schools of nursing and medicine for the education piece. And then we conducted interviews with other key informants to confirm or clarify or expand the responses that we received in the survey. Focus groups were then held from individuals within the regions and sectors to comment on the information collected publicly and from the surveys and from the interviews. And then a final verification of the results was undertaken with provincial and regional leaders. So you can see, based on this methodology, why it could take so much time to develop an atlas, because we really are dependent on the time of all the people that were involved in this, which, and people being as busy as they are, it can be tough to pin them down and to get them to respond, but we did. So one of the things I do want to clarify here is Pallium Canada's role in the development of this atlas. Our responsibility at Pallium was to ask the questions, gather the data, and report on what we heard. Our role isn't to make recommendations or interpret the findings through a particular lens or filter, or adjust the information in any way. So this atlas is intended to serve as a true reflection of what was shared with us by the stakeholders across the province. It really reflects their voices, their insights, and their experience form the foundation of this work. Our goal throughout has always been to provide a clear, evidence-informed snapshot of the current palliative care landscape. So to summarize, we approach this work really as facilitators or stewards of the information, committed to ensuring that the data remains accurate, transparent, and grounded in what we have heard directly from those working in and affected by the system. Next slide, please. So the provincial edition of the Atlas is divided into two parts. The first part reports at a provincial level, and then the second part at a regional level. And the regional part is then further divided into 5 subsections, each one corresponding to one of the 5 regional health authorities in British Columbia. And the information within the Atlas is shared in a few different ways. So we have data that's presented on maps that will present different shades of blue based on the levels of or presence or availability of a service or a resource. And you can see an example of that on the screen on the right-hand side of the slide with respect to access to specialist palliative care. And data is also presented through dashboards where the extent to which a service or resource is available is indicated through colored circles. And the circles can be, accompanied by a letter V that indicates, a variability in that service. And then finally, there's a little megaphone icon that you see there will be shown whenever we want to highlight an innovative program or strategy. The Atlas also has a comprehensive data dictionary that provides more information on the specific terms or the definitions and the standards for the benchmarking of palliative care services used in the Atlas. Next slide, please. Before we dive, I hand the floor over to Leonie. I want to just take a moment to explain one of the formats that we've used to present the Atlas data. So we do have the Atlas in a PDF form, but we've also presented the Atlas data in something called a story map, which is something that's developed using ArcGIS technology, thanks to our partners at Esri Canada. A story map is an interactive web-based tool that combines maps with narratives, images, multimedia content, really that serves to tell a story. So it's a very powerful way to present what can be very complex information in a way that's easy to navigate and is visually quite engaging. So for the Atlas, this format allows users to explore palliative care data and insights by region. So you can scroll over data with your mouse. You can just, expand the information so you can really do a deep dive into different geographies and what's present there. Again, in addition to that static PDF report, this really does give us a dynamic digital resource that we can continue to update and expand over time. And I believe on the next slide is just the sample, as you can see here, of an interactive story map that shows access to specialist palliative care using those buttons, those little radio dials, and then the access to specialist care shown on the map. Okay, so let's go on to the next slide, please. Um, Again, before we dive deep into the findings, just want to take a moment to acknowledge the cover design of the BC edition of the Atlas. The visual elements were chosen intentionally to reflect the natural beauty and the diversity and the character of the province of British Columbia, and with its coastal landscapes and its mountain ranges and its rich ecosystems. I think what we really tried to do here is to ensure that the cover sets the tone for what's contained within the Atlas, right? A thoughtful, place-based look at palliative care in BC that honors both the data and the people behind the data. So let's get into some of the high-level key findings, and Leonie's really going to get into this in more detail, but I think it's important to start with the fact that BC does have really a vibrant and a well-developed palliative care system with high levels of access in most regions to specialist level palliative care services in hospital and community settings. However, rural and remote communities do continue to face significant barriers, struggling with both limited service availability and challenges in recruiting specialized professionals, leaving many without timely specialized care. Secondly, the BC Centre for Palliative Care does play a crucial role in advancing palliative care. They support best practices, they foster collaboration, they promote integrated care models right across the province. And their initiatives, including the Compassionate Communities Movement and their long-term care collaborative, do empower communities and healthcare providers with the tools and supports that they need to improve palliative care delivery. So I want to give them a nice shout out there. Thirdly, if you look at hospitals, most medium to large hospitals in the province have access to specialist palliative care teams, ensuring access to, of course, consultant expertise. But the integration of palliative care across various hospital inpatient and outpatient services is minimal to low overall, especially for non-cancer services. So better integration of palliative care within cancer and non-cancer services is needed to improve care. All physicians in the province, within hospitals and communities, do have access to a provincial on-call palliative care physician telephone consultation service whenever necessary. And this is a vital resource, but further integration into everyday patient care really is crucial if we want to improve overall care delivery. Fourthly, across the province, community-based palliative care is strong, especially in medium to large urban centers. And these areas benefit from home-based care services, hospice care, strong community support systems. But again, if we look at the rural and remote regions, they have less, in some cases, less than 10% of the coverage they need to access specialist palliative care clinicians. So in these regions, access is largely virtual, and in many regions, after-hour support relies on that provincial physician-led on-call line. Fifthly, there's a overall adequate number of PCU beds for the province relative to the population size. However, two of the regions were found to have inadequate PCU beds for different reasons. One region has no PCU beds, and in another region, these beds are primarily designated for use by palliative care rather than being dedicated to palliative care. Designated beds may not be available for patients with palliative care needs when admission is needed, and staff may not have adequate expertise in palliative care. The number of hospice beds in the province is largely adequate when calculated using a conservative measure of the minimum recommended numbers, but when combined with PCU beds, for a total number of inpatient palliative care beds available, the number is inadequate and more are needed to meet rising population needs. And then lastly, it's worth mentioning that BC does have a highly engaged palliative care community with over 120 compassionate community initiatives supported through a C grant program from the BC Centre for Palliative Care and a strong volunteer network that supports palliative care at the grassroots level. Volunteers, caregivers, hospice programs really serve as vital hubs of support that strengthen local networks of care and provide essential emotional, social, and practical assistance to individuals and families. So there you go, at a very high level, some key findings from the provincial Canadian Atlas of Palliative Care for BC. I'm now going to hand the floor over to Leonie, who are going to get into some of the results in the region, starting first at the provincial level. So Leonie, over to you.
Thanks, Jeff. Yeah, we can go on to the next slide, please. So we'll spend about 15 to 20 minutes just reviewing some of the key findings at the provincial level and then showcasing some of the additional information that we drilled down into at the regional level and really just encourage you to dig deep into the story map and the online reports for the regions that you belong to or the regions you're interested in to really get into the details of those because there's so much rich information there. Of course, we don't have time to review it all today. Next slide, please. We can go then. Thank you. Yeah. So we start off the atlas by really grounding the work in the population needs. So both at the provincial level as well as the regional level, this is just one piece of the information we capture in demographics. We report on population size, population density, age demographic causes a number of deaths, and just wanted to highlight here for British Columbia in particular that, like in many places in Canada, we have a wide variation in terms of population density from areas that have zero 0.5 people per kilometer squared, such as in the northern region, up to very dense population of 125 people per square kilometer in the Fraser Health region. So again, how services can best meet the needs of the population are very much grounded in what is possible within these very large geographic areas. So very important to always kind of ground ourselves in demographics. Next slide, please. So under the policy domain, we report on both policy structures and laws, as well as formal strategies for particular aspects of palliative care, and then funding, of course, for a wide different variety of aspects of essential services for palliative care. And what you can see for BC is that, overall, there's a very good infrastructure in terms of the policy framework level for palliative care. There is provincial legislation pertaining to advanced care planning. There's no specific law to ensure palliative care access. There is a formal provincial plan for palliative care that's called the End of Life Care Action Plan. That is a little bit older, so important to note that it is from 2013, and so opportunity there perhaps to improve that based on current 2025 population needs. That strategy includes specific aspects to improve palliative care in home and community care, hospice services, long-term care, and emergency services, but importantly doesn't specifically address the unique needs of rural and remote communities, which, as Jeff summarized in the kind of high-level results, is that there's a disparity in access, and so another opportunity there perhaps to strengthen palliative care through a policy strategic level. From a government funding perspective, as in many areas of Canada, in-hospital funding is very much full in terms of all equipment and medication and services. But once you move out of the hospital into the community setting, whether it's hospice or home, there's typically tends to be partial funding, and that's the case for BC as well. There is a provincial palliative care benefits plan called Plan P, which includes medications and some supplies for people with palliative care needs that can be put into place for those who are eligible. Next slide, please. So looking at services, so we dig into here again at a provincial level, the total number of inpatient beds for palliative care. So that includes hospice beds, and those can be within freestanding residences, or they can be designated hospice beds within, say, for example, a long-term care or a community hospital. So all of those are included. The ones that are outside of freestanding hospice are reported here as other hospice beds. And then we also look at the inpatient palliative care unit beds, whether those are in like a co-located unit or distributed, shared, for example, with medicine beds or oncology beds in a shared unit. Those are the other palliative care beds. So you can see here that in overall, at the provincial level, there are 10 dedicated palliative care units. About 50% of the beds that are needed for inpatient palliative care, so a total of 76. And as Jeff mentioned earlier, we only report on dedicated beds, not designated beds. And the difference is that the dedicated beds are solely used for the purposes of palliative care. They're available when needed for someone who needs admitting with the palliative care, and the decision to admit is based on the palliative care team as opposed to another team at hospital operations that we have to kind of go and ask if we can admit a patient, and sometimes those beds aren't available. So those we count as designated beds. And those don't have that dedicated specialized palliative care team with the expertise to address those complex needs. So the adequacy of beds for the population needs using this conservative measure Jeff mentioned called the Catalonia formula of a total of 10 beds per 100,000, of which 3 of those should be palliative care unit beds and 7 should be hospice beds. Those are determined again using dedicated beds. So really important to know, and there's definitely some room to move on in terms of adequacy with even making some designated beds into dedicated beds, for example. Hospice beds overall, as you can see, are about 90% of what's projected for using that Catalonia formula. And anything within kind of 10% of a target range we considered as adequate for the purposes of the Atlas report. Thank you. Next slide. So then we looked at services within acute care settings, so access to specialist palliative care teams in hospitals, and overall, there's partial high access. Again, largely in-person, on-the-ground teams that serve in the larger kind of medium to large urban centers, and in the more rural and remote areas, a lot of that consultative support from the specialist teams is virtual. Some have some teams that go, for example, to northern region once a week where they might go do in-person consults and then are available virtually to support. And some more rural areas really rely on that 24/7 physician consult line that Jeff referenced earlier, which is very much a vital service to many regions in the country. And so just wanted to make a shout out to that, just how important it has been and well necessary across the province. So in terms of funding for physicians, most often it's different service contracts within the regions as opposed to fee for service. Next slide, please. So within other inpatient units, so now we're talking about oncology, medicine, surgical units in the hospitals, as well as various other specialty outpatient clinics. We looked at both cancer versus non-cancer. You can see that while there's that robust consult availability for specialist teams in the hospital, there's not as much integration into those other inpatient units. And this is the teams themselves providing a palliative approach to care to their own patients and then liaising and integrating the specialist team when needed. In the outpatient setting, more availability at a partial level of palliative supports through the oncology teams for patients with cancer, and very little, minimal to absent for non-cancer. And that was fairly consistent across all 5 regions. But again, you can dig into that at a regional level and get more details on each of those areas as you're interested in. Next slide, please. At a community level, there's quite robust access to specialist palliative care teams in the community. There is a V here for variability, and as you can see in some of the color shading in the map on the right-hand side, one area in particular, interior, lacks access to community specialist teams, and a lot of variability as well around the 24/7 access across the province. So again, to dig into each of those regions, go to the regional maps, but the rural remote areas tend to rely again on that virtual support, both after hours as well as during the daytime. Next slide, please. In the sense of home care, many of the palliative home care services across the regions are provided by generalist home care teams, and that's just the nature of a big geography. The bigger centers had more dedicated, specialized palliative home care teams, and after our support was much more limited, of course, than in-person support during the daytime, and relied largely on virtual support by phone from many regions, just given again the big geography and variability across the regions, which would be expected. Next slide, please. Primary care, like in many places in the country, is very challenging. Family doctors, besides being short-staffed, there's lots of demands on their practice, and overall, the provision of primary palliative care by family physicians and primary care teams is on the lower end, kind of partial low. Typically, providing a palliative approach to care for patients in their clinic setting, but then once you get out to people who can't come to the clinic anymore or need that after hours 24/7 coverage, very little, minimal to absent across the regions, of course, with some variability. More family physicians and primary care clinicians in the more rural areas made themselves available to their own patients for palliative care needs after hours and for in-home visits than in the bigger urban centers, which is fairly consistent with other places in the country as well. And there is training available for professionals in these regions if they would like to get more confident and equipped in providing a palliative approach to care. Similarly, in the rural and remote regions, the access was on the partial low side to specialist palliative care teams in the community, primarily, as we've said earlier, being virtual through phone or telehealth supports. And again, there's funding and training that can be requested and put into place for folks working in those settings. Next slide, please. In the long-term care sector, there's a lot of work being done to, in fact, led by the BC Centre to improve education through the SPA long-term care program across long-term cares in all the regions. The integration of the palliative care approach is more variable and at this point is still on the partial low side, but there is really good access to specialist teams for consultation across all of the regions should that be needed. There are no specific standards or indicators for providing palliative care or palliative care approach in long-term care. And we were told that there's not specific funding for education, although the SPA long-term care initiative is certainly going a long way in that regard, led, as I said, by the BC Centre. Next slide, please. Hospice services. So this is really looking at hospice community organizations that, are such a vital part of our communities and provide a lot of the volunteer support, grief and bereavement care. And there's quite a large number of community hospice organizations, which we'll show you in the upcoming slide, that are very engaged in supporting their local communities, and paramedic emergency services are available at the community level with training that has been put out provincially. So all paramedics in BC can have training in LEAP paramedics through the BC Emergency Health Services Program. And I think about 50% of the paramedics have been trained so far. The rollout of providing a palliative approach to care in their services is variable across the different regions. And again, you can dig into some of that information in those regional reports. Next slide, please. So in terms of community engagement, looking at palliative care resources, lots of advanced care planning resources and competencies have been specifically developed for different professions and levels, both primary, generalist level palliative care, as well as specialist level palliative care. And just a shout out to the BC Interprofessional Palliative Care Competency Framework that has been, discipline specific competency have been developed. So that's a great resource. And then again, the BC Centre for Palliative Care is really doing a lot of work to promote essential conversations, serious illness training, and they've adapted the serious illness conversation guide to various different populations as well. So for example, structurally vulnerably housed individuals as well as Indigenous. There's a pediatric version as well. So lots of tools there to promote advanced care planning and serious illness conversations. Next slide, please. We don't specifically report information on system performance, but we capture what is being done at a provincial and regional level. And so each health authority in British Columbia has a healthcare report card that are published multiple times a year on key priority areas that the Ministry of Health and the health authorities designate. And there are some system performance indicators that have also been captured at a federal level through the CIHI reports, as well as the Canadian Partnership Against Cancer reports that can be leveraged. Next slide, please. At an education level, so lots of really great education in palliative care happening. We specifically report on physician and nursing education. In the original methodology for the atlases, we had hoped to report also on social work schools and training in palliative care, as we know social work is such a vital part of holistic palliative care. But unfortunately, we were not able to get that information pretty much across the country. So we focused on nursing and medical school education. While there is the University of British Columbia Medical School, it has obviously multiple campuses where education is being provided across the province, and there are 21 nursing schools. There are dedicated specialist training programs for physicians in palliative care, including in both adult and pediatric through the Royal College as well as the College of Family Physicians. And nursing specialization is available through the National CHPCN certification, and lots of active and good education being done. One example is that all medical students in fourth year do take part in the serious illness conversation training. Jeff, were you going to jump in? No, okay.
No, I was
I'm
just
like,
checking.
where? You're welcome.
I was just checking the
Yeah.
chat and I pushed the wrong button. Sorry.
Okay, perfect. No worries. Next slide, please. Lots of professional activities, and I think this is something like, is very remarkable. That's very, very significant amounts of research and education and services to promote improving quality of palliative care happening. Lots of conferences and symposium. We give sample publications both in quality and research under each of the regions, so you can kind of see who's doing what in what areas, get a flavor for all of the robust academic activity that's happening, largely through the university-led centers, but in other smaller centers as well. So very robust professional activities, which is a real marker of palliative care development in a region. Next slide, please. In terms of focus populations, just to highlight pediatrics in particular, and then we'll come to the other ones, but there is a pediatric hospice residence, which is Canuck Place, which has 2 campuses. There are outpatient palliative care programs that are supported through Canuck Place, which are, obviously in one particular region, but there is virtual support across the whole province that is being provided by Canuck Place. And so, and they also provide 24/7 consultation across the province, including after hours teams. So anyone who needs pediatric palliative care support can access it. And LEAP Pediatrics is being rolled out, and other educational initiatives for pediatric palliative care are available. So just I really, I should have we should have put the megaphone icon here. It is in the report. Just a shout out to the amazing work and national leadership actually Canuck Place is playing in the landscape of pediatric palliative care. And then another, an opportunity is that there's no specific formal strategy for pediatric palliative care. Certainly something that could be looked at the provincial level. Next slide, please. With respect to other focused populations, we include, as Jeff already mentioned, 2SL LGBTQI+, and homeless and marginally housed, incarcerated, recent immigrants and refugees. And there are no specific formal strategies or programs or initiatives at a provincial level. However, there are examples of very important initiatives and programs that are being developed in some of the regions. One example would be the PORT program for homeless and marginally housed on Vancouver Island. And we, certainly showcase the things that we were made aware of that are being done to build some initiatives in each of the regional levels, but nothing formal happening provincially. Next slide, please. So in terms of community engagement, this to me is a real highlight of the British Columbia landscape for palliative care. There's formal strategies, programs and initiatives, and training for volunteers. The volunteer movement is very strong in British Columbia, and lots of compassionate community initiatives and engagement happening. A lot of that spurred by the BC Centre for Palliative Care, which has been supporting the rollout of compassionate communities good grief and bereavement services and programs for informal caregivers, although no formal strategy for supportive informal caregivers. Next slide, please. And then I'll just highlight, so that's kind of the quick run through of the provincial level results. But again, just spend some time on the story map and in the report, because what we don't have time to also point out today is with every result that we report, there's a large context box that really goes into detail about what all of the different programs and frameworks and giving examples and the nuances of capturing what all of this really means at the provincial and regional level. So do dig into that. At the regional level, we do report a bit more detail on the palliative care beds. So if you can go to the next slide, please. Just wanted to highlight the additional level of detail that we can go into. And really you can see this really nicely in the story map. So we actually show specifically where, like, in the region the hospices are located, where the palliative care, in this case, this map is the palliative care unit beds, exactly where they're located, how many beds there are, and then the type of facility that they're in. So in this case, in Fraser Health, there are 3 palliative care units. Each of them have 10 beds, and they're all located within an acute care hospital setting. But if they were in a different type of setting, for example, a continuing care hospital or a community hospital, we would have a different icon that maps the type of facility that you can see in the legend. And then you can look at where the earlier maps for population density is, and ideally in future state we'd be able to overlap these and really get a sense of where the hospices and the palliative care units are and how many beds compared to like the population density. At this point the maps are separate, but you still really get a sense of geography and need of the population. So, and then we go a bit deeper into the adequacy based at a regional level. So, really helps us to see other opportunities to better meet population need. In this case, even though there are 30 acute palliative care unit beds, and they're really doing amazing things in Fraser Health with focus on acute symptom management rather than replacing, a hospice as an inpatient bed, which is in some other regions where there could be more need for an acute palliative care bed, but still there's only half the number of beds that that region needs based on that conservative measure of population need. And then the next slide, we'll just look at hospices very briefly, and then I'll hand it back to Jeff for the summary. So at the hospice level, if you could go to the next slide, please. Mhm. Oh, I thought there was a hospice one. Oh yeah, there we go. Okay, thanks. You can see again just where the hospices are located. We differentiate whether it's a freestanding hospice, whether it's hospice beds that are co-located within another unit, for example, long-term care, and whether it's pediatric or adult. So you can actually, on the story map, you can hover over each of these little points, and it'll tell you like more about each of the facilities, how many beds, where they're located, their address, some additional information. So it's just a bit more of a higher level of functionality on the story map than we have in these PDF reports. And so what you can see here is that overall Fraser Health has a fairly adequate number of hospice beds based on regional needs, and a large number of community hospice organizations that are supporting all those functions that we described earlier. So I think that's it for me, Jeff. I'm going to hand it back to you to
Sounds
wrap
good.
up for us, and then lots of time for questions.
Absolutely. Great. Thanks so much, Leonie. All right, let's go to the next slide, please. All right, so what we just wanted to do here is just to give you a sample of how one could go about leveraging the data that's contained in the atlas. And while, as I said right from the outset, our goal isn't to present recommendations, what this slide really does is just identify some potential opportunities to be considered. So there's a number of bullets here on the slide. They're split between policy and service. So if we look at the Atlas findings from a policy perspective, and Leonie had mentioned this a little while ago. The BC Provincial End of Life Care Action Plan was released back in 2013, so it's over 12 years old. So there is an opportunity to update this plan using and leveraging the insights from the Palliative Care Atlas to reflect current needs and priorities. And from a services perspective, number of opportunities. One, we mentioned here about increased funding for hospices to reduce the user pay fees, and that can be done by looking at models from other provinces. And if you look at sister province Alberta, where user pay fees are not required, maybe something that can be more deeply looked at for learnings to apply to BC. Reestablishing the dedicated PCU beds in Island Health, which were lost during the COVID-19 pandemic, is another opportunity that should be under consideration. Expanding the presence of specialist palliative care teams in the interior health region as well. And we talked a lot about the usage of the provincial helplines. And it would be interesting to understand, maybe to conduct an evaluation of how that line is being used. So what's the usage of it? What is the impact of that line? As we said before, it really does serve as the only access point to specialist palliative care services for many communities. And of course, as we said from the outset too, I think it's incredibly important to make sure that everything that we've done here for this atlas is replicated in service to the Indigenous peoples to map out palliative care across the province, again, adhering to the First Nations principles of ownership, control, access, and possession, OCAP. We feel strongly about that as well. So that just gives you just a smattering of potential opportunities. There are many more for sure. And if we go on to the next slide, yeah, I believe that's a wrap. So we're going to just we're going to pause here and open it up for any questions or comments anyone might have. So, Leonie, I see here, were there any discussions of the number of nurse practitioners who are providing specialist palliative care in the province?
Yes, we weren't given that specific information from any of the regions that we met with. Not sure where that information would be available because, again, like, would it be specialist nurse practitioners working in specialist teams, or do you mean nurse practitioners providing like primary palliative care? So um, that might be something the regions might be able to give you the specialist information, but certainly nothing that was shared with us.
Wendy's question around other atlases. Good question. So we launched the Ontario Atlas on Monday. So you'll be able to access in fact, if I'm not mistaken, I believe it's already live, but we do officially launch it on Monday. And the Alberta Atlas, while an earlier version has already been launched to meet some provincial deadlines, the revised version of that atlas to reflect some of the domains and elements that we've just been through, and including the format of the atlas, that will also be launched at a date still to be determined, but likely in the fall. So thank you, Wendy, for that question. I'm just looking in the chat here. See anyone else have any questions? I mean, I think one of the things I just want to end with is that first off, to get access to the BC Atlas, if you go to pallium.ca /BC Atlas, that'll take you right to the Atlas itself, where you can look at, as I said, the detailed PDF report or the actual story map as well. This really is just the beginning, right? The information that we've presented here ultimately is meant to be leveraged. So we do encourage people to go through the results and to use it almost like a business tool to inform initiatives, funding, policy needs. Please do visit that and more to come on that. But I want to see here, Clara, any recommendations, suggestions for health authorities to restart open dedicated versus designated PCU beds? Experience in the interior is designated beds were started, but perhaps with COVID, they have shifted.
Yeah, so there were no designated or dedicated beds in interior for specialist palliative care. The only beds that were available are hospice residence beds. In Island Health, as Jeff referenced, the PCU used to be dedicated beds, and then during COVID, the operational decision making on admissions to hospital got taken away from the palliative care team, and now any admissions have to be negotiated, which makes it really tough. So that team, I think, can now take this information and look at the standards around palliative care and access to beds for their population need and hopefully articulate why it's important that the oversight of those beds be brought back under this dedicated to really meet the needs of the population. So we're hoping this type of tool can be used for advocacy and to, reinstate those beds so that they are available for the folks in that region who need them. But I think Interior has some work to do in terms of creating any type of inpatient palliative care bed, and there's no specialist palliative care team providing consultation. There's only specialist support for cancer patients and part-time through the Kelowna General Hospital, like the at the cancer center. So it's very limited specialist palliative care there. So hopefully this will be an opportunity to look at how to better meet the needs of people living in that region.
Sarah has asked a question around approach to working with others. So what? It's a great question, Sarah. We're using the BC, Alberta, and Ontario Atlas to embarrass all the other provinces into getting their atlas done. No, we're not doing that. We are seeking funding from each of the province and territories, but also from the federal government to complete the remaining atlases. Because you're absolutely right. We're motivated to get this done for every province and territory and a federal atlas and the atlases for First Nations Inuit Métis as well. So there's still a lot of work ahead of us, frankly speaking. But that work is actively underway, I can assure you. Thank you for that question.
Mhm.
Okay, there may need to be exploration of what hospice beds do in terms of care. Ontario Health, as an example, the hospice in Kelowna provides active PSM that a PCU might otherwise do in a hospital setting, as opposed to other hospice beds that are end-of-life care only.
Yeah, so that's a good point. And so one of the metrics that we look at in our data dictionary, we really delineate what is considered an inpatient palliative care bed, and we actually capture qualitative information around whether those are being used for end of life, whether they were acute symptom management, or whether they were mixed units. And so that level of information was captured. Um, I think the difficulty is that hospices are staffed very differently in terms of the type of staffing ratios and things to manage acute symptom management, and there may be different goals of care requirements. So a hospice, even that does symptom management, doesn't replace an acute inpatient unit by the type of complexity and acuity of care earlier on in an illness trajectory that people need. And so there's definitely some overlap with inpatient beds in hospice and PCU beds. But I think overall, if you look at the data, there needs to be at least 3 out of 10 that are for more acute palliative care, where people are brought in. I call them buff and polish units, right? People are brought in with a symptom crisis. The symptoms are optimized and then they're able to get back to their usual place of care, whether that be home or another residence. Whereas end of life care and that is 7 out of the 10 beds really to focus on optimizing people, whether that's in a hospital or hospice. So I think if you look at it in terms of those metrics, that's where the planning and health service delivery piece can come in. And in some smaller communities, it doesn't make sense to have a freestanding, 10-bed hospice. Maybe you need to provide that high quality end of life care in a community hospital setting because that's the best use of resources to meet the need in that area. But it's really about the way the beds and the type of palliative care those services can provide. So hopefully that makes sense with the 3 and the 7 out of the 10 beds. I don't know, Jeff, if you want to add anything.
No, no, that's good. Thank you, Leonie. And thank you for that question. That's
Hmm.
fantastic. Really good questions. Any other questions or comments? Okay. So I know we're almost at the top of the hour. I know just in terms of wrap up, first off, thank you all for joining us. Thank you for some great questions as well. And what we'd like to encourage everyone to fill out the feedback survey following this session. And I believe a link is going to be added to the chat function, if I'm not mistaken. Look for that in just a moment. Please do fill that out. It really does help us improve these sessions going forward. We really do leverage this data and we report on this data as well. So give us your honest feedback. That would be fantastic. So there you go. I see it. It is in the chat function now. Uh, well, if there's nothing else, Dr. Herx, thank you so much for your time and for your collaboration and partnership in being a key individual in developing this atlas. And again, to all of you for taking time out of your busy schedules to join us today to learn more about this atlas. I hope you do visit the website to take a look at it and to leverage it and share it widely. All right, look for more coming soon, we hope. Take good care. Have a great rest of your day.
Thank
Thank you.
you. Bye.
Bye bye.